This is the last talk of the session, and I'll dive a little bit into metabolic networks in neurodegenerative dementias. So just to, with a brief introduction, neurodegenerative dementias are a group of syndromes caused by abnormal protein accumulation. The most common neurodegenerative dementia is Alzheimer's disease, followed by dementia with Lewy bodies, frontotemporal dementia. In clinical settings, still the misdiagnosis is not uncommon, and accurate diagnosis is needed for prognostic reasons, patient management, clinical trials, and also for inclusion for new disease-modifying drugs. That's why we are turning to various biomarkers that we can use, and one of such biomarkers is imaging with FDG PET. So FDG PET scan, just from a visual read, it looks like this. This is for a normal individual. If we look at patient with dementia with Alzheimer's disease, we see changes in precuneus and temporal lobes, dementia with Lewy bodies in occipital lobes, precuneus to a lesser degree in temporal lobes, and frontotemporal dementia, changes are seen in frontal and temporal lobes. And from the visual read, it's easy to distinguish these two scans, but in the clinical practice, syndromes are often overlapping, so that's why we are dealing with all this fancy methodology to improve diagnostic decisions. So scans can be analyzed in various ways. First with visual reading, univariate analysis that we heard a lot about, and multivariate analysis. And this is not a novel concept, and this was already mentioned in the previous talks, is that multivariate analysis has been used to study relationship between these spatially distributed clusters since the 80s. One such, so we have various multivariate approaches that we can use, and I'll focus on the principal component analysis in the next couple of minutes. So this has been already introduced, so just to briefly recap it, here we are first dealing with a inter-subject, so we are identifying patterns on a group level. So we begin with disease and healthy individuals, obtain the data, apply principal component analysis to derive a pattern that is characteristic for a certain disease. Then in the next step, we can prospectively quantify or calculate the expression of a given pattern in a single patient. So here we have our lady, she is scanned, we use the disease-related pattern that is characterized by regions of reduced metabolic and increased metabolic activity, a so-called network of functional connections. This is then calculated, a dot product is obtained, and a personal score is assigned to that lady scans, and we can then do whatever we like with this personal score. So here we are comparing it to disease and health individuals, and we can see that her score is in normal range. So with the methodology behind us, I'll now introduce a couple of examples related to the dementia field. So first, the so-called Alzheimer's disease-related pattern. This pattern was first identified, as Igor mentioned, years ago, so already in 2004, first by looking at cerebral blood flow scans with radioactive water. This is a radioligand that needs to be produced on site, injected directly into patients. The patients need to be scanned, so it's quite burdensome to obtain these images. The data is noisy. However, even with this data, we can identify a so-called ADRP pattern which correlates with cognitive impairment. Then, in subsequent years, the pattern has been identified in using FDG PET, first to show that it can distinguish between patients with dementia and healthy controls. Then various groups across Europe and the United States have found similar topographic patterns, and it was shown that the pattern is also expressed in patients with mild cognitive impairment, so pre-dementia stage. Then the question is, are the patterns reproducible, or how can one pattern be transferred to from the patient data from different scans? This is what we looked at in this study, so rederiving ADRP in data from Ljubljana, so this is the identification cohort, and then prospectively quantified in our data and two cohorts from United States to show that the pattern can be applied also to novel data from different centers. Another question is not just if the pattern's topography can be characterized in different cohorts, but whether or not we can the pre-processing steps affect the topography. So if this is a robust biomarker, or if it's affected by selection of pre-processing steps. And in this study, our research group have shown that the topography is indeed stable across different sample sizes and different smoothing parameters and so on. So first we looked at cerebral blood flow, then FDG PET, and this is a very recent application where they use dynamic PET imaging. So they used amyloid tracers which bind to amyloid pathology to derive so for dynamic PET imaging, they derive something that resembled ADRP. So if you scan the patients in the first couple of minutes while the tracer is still distributing around the brain, it's not binding already to the amyloid pathology, but it's still distributing. So we get a proxy of cerebral blood flow. And if we calculate then the expression of this kind of pattern, we can compare it to the FDG score. And once again, we can see that even looking at this, the dynamic PET derived pattern, this is expressed more in patients with dementia than healthy controls or MCI. Furthermore, it was shown that the pattern correlates with measurements of cognitive impairment. And not just that, but also a couple of studies looked at if we can use it to track or predict disease progression. Here is an example shown. So pattern expression is measured at baseline in patients with mild cognitive impairment. And those patients shown in blue, so this is this line, have the very high expression of the pattern, and they are progressing faster from mild cognitive impairment to dementia. So it can be also used as a prognostic biomarker. And looking at the pattern expression longitudinally, I'm just focusing on the right part of the slide. Here, the patients are measured at various time points across 6 years. And this is a group of patients with mild cognitive impairment that are converting from MCI to dementia. And we can see that their subject scores are increasing monotonically with time. And as this scores increases, this correlates with increasing cognitive impairment or worsening of cognitive impairment. So to sum it up, the first part of my talk, I have shown that ADRP is a robust brain biomarker of Alzheimer's disease. The topography was proven stable both in different patient cohorts and with different statistical approaches. The expression correlates not just with cognitive impairment, but also increases monotonically in patients who are converting. I've shown the part of data converting from MCI to dementia. What we also seen in a small group of patients that are converting from healthy normal to MCI, that the increases can also already be seen there. And the pattern expression scores can be used for prognosis. Then the second part will be devoted to dementia with Lewy bodies, which is the second most common neurodegenerative dementia. And similar to ADRP, though this work is more recent, various groups have tried to identify the so-called dementia with Lewy bodies related pattern. And here, this is a busy slide, but there are 5 DLB patterns that were identified across the world. However, none of them has been confirmed to also work in data from other centers. However, it was shown in single-center data that it bears diagnostic value to distinguish healthy controls from DLB and DLB patients from patients with dementia due to Alzheimer's disease. So there is a lot of overlap between these two because DLB is on one hand related to Alzheimer's disease, Alzheimer's dementia, and on one had the Parkinson's disease. This is what they looked in this study. So comparing DLB versus other alpha-synucleinopathies, and they show that DLB-RP is mostly expressed in patients with dementia with Lewy body as compared to patients with PDD with dementia, REM sleep behavior disorder, PD without dementia or MSA. As I said, DLB can be related both to Alzheimer's and Parkinson's disease, and we then asked ourselves if we can quantify how these patterns are overlapping or related to one another, and by trying to explain the voxel variance of the patterns, we show that DLB RP can be a third can be explained by PDRP, 1/4 with ADRP, so Alzheimer's pattern, a non-significant percentage to PD cognitive pattern, showing that the mechanism of cognitive impairment might be different in dementia with Lewy body as compared to Parkinson's disease, leaving a third of the variance unexplained, which can be thought of as DLB-specific changes. So lastly, the methodology has been applied also to other dementia syndromes. As already shown, frontotemporal dementia-related pattern has been identified in 2 different populations, and the pattern can be prospectively quantified. It works in different center data, and this has been shown. So I'm showing this here's some nice work from Tomasz, who looked at how the connectivity inside of this FTD pattern is changing by applying graph theory, which is a form of discrete mathematics, in which we define the nodes, and we see how these nodes are connected in healthy individuals, and then they become disconnected in patients with FTD. Looking at finishing with other dementia syndromes, in Parkinson's disease dementia, groups have studied Parkinson's disease cognitive pattern, which increases also already at the MCI stage. This topography has been replicated using resting state fMRI data. Similarly, a pattern was identified for Creutzfeldt-Jakob's disease and progressive primary aphasia, but these are just single studies currently out there. So to summarize, my talk and I guess the talks before me, why even bother with molecular connectivity? I hope that I've shown that the assessment of molecular connectivity can offer new insight into normal and pathological brain functioning, that the markers are robust and reproducible measurements of brain connectivity, and they have been shown useful in both clinical and research setting. Lastly, I'd like to acknowledge my collaborators and you for your attention.